Hi class, welcome to our last unit, Unit 9, and this should be for most of you pretty much a review of covering fluid and electrolytes. So let's get started with a review of our fluid balance. So basically our fluid balance, the goal is to maintain homeostasis. So a balance between what's going out and what's coming in, and then also a balance between our acid and bases. So a general rule is we want to just replace what we take out. And that's what this slide shows you, is how we lose water in measurable and immeasurable ways. So we are about 60% water in adults and more than 60 in kids, less than 60 in elderly. And there are two types of ways to lose fluid. There's sensible fluid loss, and that's measurable. So that is fluid loss through the kidneys via urine and the intestines via fecal. Then there's insensible fluid loss. That is unmeasurable, and that is our evaporation from skin, lungs, and breathing. And that is why when we exercise, we have to increase our fluid intake to match what we lose, not only through our sweat, by our increase in respirations as well. Excuse me. And then remember that our acid-base balance is dependent on hydrogen ion concentration in the body fluids. And so where are the fluids located? 40% of our fluid, or 40% of our total body weight, is intracellular, so inside the cells. Extracellular is about 60% of our total body weight, and that includes the interstitial fluid and intervascular fluid, so what's in our veins and arteries. And then there's a third type that we really don't spend much time discussing because it just doesn't change very much, and that's the transcellular fluid. And that's the fluid that's in like our cerebral spinal fluid, our pleural cavity, our lymph nodes, joints, and eyes. So within those fluids, there's different fluid types. And basically what we want to do is we want to maintain fluid balance between the compartments. So intracellular, intravascular. And the three main types of fluid are isotonic, hypotonic, hypertonic. With isotonic, there's no net fluid shift related to the solutes inside and outside the compartment because they're basically equal. Same amount of stuff inside and out. Hypotonic causes fluids to shift into the spaces because there is a need to equalize. Hypertonic fluid shifts out of the spaces because, again, they want to equalize. And then fluid moves through different methods. This is just a review of that. And it's just a reminder that intake and output, all routes must be measured. And that includes urinary output, bowel movements, drainage from wounds or drains, nasogastric suctioning, ostomy output, etc. Also a reminder that 2.2 pounds equals 1 kilogram equals 1 liter of fluid. Daily weights are the best way to monitor fluid balance. And then fluid movement. Passive or active? Passive means it doesn't require any energy. Active means some energy, or ATP, if reaching way back to pathophys, is required. So passive, there are two main types. There's diffusion, where the solutes, or the stuff in the fluid, move from high concentration to low concentration to balance equal, versus osmosis, where the fluid moves from to balance itself out. So where there's more fluid to where there's low fluid. So just a refresher on those main concepts. And then just to make things a little bit more complicated, we've got how the vascular system wants to balance things out. And so there are three major systems at work. One is capillary filtration. That's the movement of the fluids through the capillaries that results from blood pushing against the capillary walls. Then we've got hydrostatic pressure, and that's the blood pushing. The blood pressure is greater than inside the capillary wall. So if there's a greater pressure than in the surrounding fluids, fluid leaves the capillaries. If there's less pressure than in the surrounding fluids, fluid enters the capillaries. Next is reabsorption. Reabsorption is awesome because it helps prevent too much fluid from leaving the capillaries. And a colloid, for example, albumin, which is a large protein that can't pass through the capillary wall, it helps to hold water in the capillary because it's a water magnet. So the albumin, the colloid, causes osmotic pressure in the capillary, which helps maintain fluid balance. So a lot of different features come into play simultaneously to help strive for that balance. And then just a reminder, the arterial end of the blood vessels is for filtration. The venous end is the blood vessels is for reabsorption. All right, then to add another layer, we've got the kidneys fluid balance. So our kidneys, the workhorse is the nephron. And the nephron is composed of the glomerulus and the tubule. Nephrons filter about 125 milliliters of blood every minute or 180 liters per day. And this is what's measured by the GFR. Now there are some mechanisms that automatically kick in. If the body loses 1 to 2% of fluids, the kidneys want to conserve water. But there's some minimum excretion that we need to maintain. And that minimum excretion by the kidneys is 20 to 30 milliliters per hour of urine to eliminate body waste. If it's less than the minimum, the patient has renal impairment and impending renal failure. And that's why watching urine output is so important. To pick up and detect those changes in output can give us a heads up on problems that are heading down the pipeline. Next, let's talk hormone fluid balance. So ADH is also called vasopressin. ADH is a critical hormone. It's produced by the hypothalamus, stored and released by the pituitary gland. When is it released? It's released either when there is an increase in serum osmolality or a decrease in blood pressure. When ADH is released, there's increased kidney reabsorption of water, so we're going to keep more water on hand, which results in more concentrated urine being produced. It makes sense. If there's inhibition of ADH in response to a decrease in serum osmolality or an increase in blood volume, it decreases the kidney reabsorption of water. So more water is peed out, which results in a more dilute urine. And this increase and decrease in ADH is what helps keep the fluid levels in balance. Layer that on top of the kidney fluid balance, the vascular fluid balance, the fluid movement, the fluid types, that sort of thing. So it's really getting a good handle on each one of these components. And so there's another important hormone fluid balance that we need to take into consideration. That's the renin-angiotensin-aldosterone system, sometimes called the RAS system, RAAS. So, renin, it's an enzyme that's secreted near each glomerulus. It leads to the production of angiotensin II, but it depends on blood flow and sodium levels. If there is a low, then there's an increase in secretion. That's how we try to ramp up our production. Angiotensin II, that is a powerful vasoconstrictor. It's going to raise blood pressure, and it also stimulates the production of aldosterone. Aldosterone causes the kidney nephrons to retain sodium and water, again raising blood pressure. Aldosterone is secreted by the adrenal cortex and initiates the act of transport of sodium from the tubules into the bloodstream. And I've got a picture here that kind of helps with this. So we've got renin, angiotensin, aldosterone. We're going to raise the blood pressure through sodium and water reabsorption. There's also some vasoconstriction at play. So if a person's on a medication that causes direct or indirect inhibition of aldosterone, we need to watch for hyperkalemia. So, and this, if your patient is on an ACE inhibitor, it blocks the ACE enzyme. So it gets rid of that aldosterone. So less sodium is retained and more potassium is retained. Then we've got just the side effects that go along with ACE inhibitors. So just to kind of put the cardiovascular with that fluid balance. One last thing for hormone fluid balance I want to touch on is atrial natriuretic peptide. It counters the RAS system by lowering blood pressure, by reducing blood volume, through increasing urine output. By increasing urine output, we increase the loss of sodium and water. That's kind of it in a nutshell. Okay, so then that brings us to thirst. Thirst is the simplest mechanism we have, that it is triggered with even small losses of fluid, but it is less effective in elderly. Elderly people have a decreased thirst sensation. And there's an increased risk with chronic condition, those who are confused, those who are immobile, older adults, that they're going to not have an adequate thirst mechanism. So we want to monitor these patients for signs and symptoms of dehydration. Specifically in the elderly, we're going to look for confusion, low body temperature, increased heart rate, or a pinched facial expression. We're also going to monitor older clients that self-fluid restrict, for example, to avoid nocturia, because that can cause fluid imbalances. And remember that the best way to monitor fluid balance is by daily weights. So let's switch gears and talk about electrolytes. So the electrolytes work hand in hand with the fluids to maintain homeostasis or balance. They are something that separates when in a solution, and they are either positively or negatively charged. There are some electrolytes that are very closely linked together, like phosphate and calcium. Phosphate and calcium have an inverse relationship. So that means if calcium goes up, phosphate goes down, and vice versa. With electrolytes, we need to balance out the positive and the negative charges to maintain electroneutrality. And most electrolytes interact with hydrogen ions to help maintain the acid-base balance in the body. So, electrolytes outside the cell. The four biggies are sodium, chloride, calcium, bicarb. Sodium is found in nerve and muscle cells. Chloride helps with osmotic pressure. It is produced with stomach acid, hydrochloric acid. Calcium serves for the structure and function of bone. It stabilizes cell membranes, transmits nerve impulses, contracts muscles, and helps with coagulation of blood. Bicarb, it has a vital acid base role. Then we've got the electrolytes inside the cell. The big three are potassium, phosphorus, and magnesium. Potassium has a role in cell excitability, nerve impulse conduction, resting membrane potential, muscle contraction, myocardial responsiveness, and osmolality. Phosphorus is found in phosphate salts and helps with energy metabolism, bone mineralization, and acid-base balance. Magnesium is a catalyst for enzyme reactions and for neuromuscular contraction in the nervous system and the cardiovascular systems. So, what are the influences on electrolyte balance? Okay, we've got just normal cell function. We've got how much fluid is being taken in, how much is being put out. What is our acid-base balance and our hormone secretions? So we've got the role of organs and glands. Our kidneys work to regulate sodium, potassium. They excrete sodium in exchange, kidneys regulate sodium, potassium. They excrete potassium in exchange for sodium retention. The lungs and liver regulate sodium and water balance and blood pressure. The heart secretes ANP, causing sodium excretion. Our sweat glands excrete sodium, potassium, chloride, and water. GI tract absorbs and excretes fluids and electrolytes. The parathyroid has a role in secreting parathyroid hormone, and that helps draw calcium into the blood and helps move phosphate to the kidneys for excretion. Our thyroid gland secretes calcitonin to help prevent calcium release from bones. The hypothalamus and posterior pituitary produce and secrete ADH. Our adrenals secrete aldosterone, which influences sodium and potassium balance in the kidneys. So a lot of organs are involved with keeping everything in check. So, medications. The big one that you want to know about are diuretics because they actively influence electrolytes. So diuretics increase urine production and require careful monitoring of electrolytes, but especially potassium. Diuretics are used to treat hypertension, heart failure, kidney problems, and electrolyte imbalances. We've got intravenous fluids. So it's a very, very common nursing intervention is to start IV fluids on a patient. But there are some issues that we need to take into consideration before we ever hit start on that IV pump. What is my client's normal electrolyte needs? Are we trying to correct the amount of electrolytes prescribed and administered? Are we trying to correct an imbalance? Were the right ones prescribed? How long is this treatment appropriate? Are there any oral supplements that we need to be taking into consideration in addition to the IV fluids? So although it's the doctor's responsibility to prescribe a specific IV solution, it's the nurse's responsibility to say, okay, does it make sense to give this to this particular patient based on what I know? Okay. So let's review our acid-base chemistry. All right, so the body has to maintain a balance for our body systems to work. We know that slight imbalances affect metabolism and body functions, and that imbalances can be caused by things like infection, trauma, surgery, medications. So we know that acids release hydrogen ions when dissolved. They give a hydrogen ion to other molecules. We know that acidic means that the pH is less than 7. Bases bind with hydrogen ions in solutions, molecules that can accept a hydrogen molecule. Basic solutions have a pH greater than 7. And then there's buffers that are critical in maintaining normal body pH. And remember that pH is a calculation based on the percentage of hydrogen ions and the amounts of acids and bases in a solution. In the body, it's blood or plasma. So normal blood pH is 7.35 to 7.45. It represents a balance in hydrogen and bicarb. If we have acidosis, it's either due to an increased hydrogen ion concentration or a decrease in bicarb. If we have alkalosis, it's either due to a decrease in hydrogen or an increase in bicarb. And know that small changes make a big difference. Because if we just get out of whack to 6.8 to 7.8, that is usually fatal. So identifying and correcting and maintaining electrolyte and acid-base balance is really important. So how do we maintain this balance? There's 3 main systems. We've got chemical buffers, we've got the respiratory system, and we've got the kidneys. So chemical buffers are those that act to neutralize, so bicarbs, phosphates, proteins. The respiratory system regulates the retention and excretion of acids through carbon dioxide, which is a strong acid. The kidneys regulate retention and excretion of bases, so bicarbonate and what is considered a very weak acid, phosphate. So the respiratory system has a short-term response. It responds in minutes and can last for hours, but then poops out. It just can't maintain it for a long term. And how it works is it regulates carbon dioxide through ventilation rate and depth. If you have slow, shallow breathing to retain carbon dioxide, which is an acid, because your bicarb, which is a base, level is high. You'll have quick, deep breathing to lose carbon dioxide when your bicarb level is low. The kidneys are a long-term response. It takes hours for them to kick into effect, but they can last for days. Kidneys regulate the absorption or excretion of bases in the urine, and bicarb is produced to replenish lost supply. So there's an increase in bicarb reabsorption, so retaining, and losing more acid, hydrogen ions, through excretion when your PA carbon dioxide level is high. So we're going to keep more bases to help offset those acids. Now there's going to be an increase in bicarb excretion or loss and an increase in acid retention when the PA carbon dioxide levels are low. So it's going to be trying to work to balance those out based on what the problem is. There's one lab that I just want to touch base on to make sure you've been aware of it, and that's ion gap. It's a laboratory test that represents the level of unmeasured ions in the extracellular fluid. The normal value is 8 to 14, and it serves to help differentiate between different acidic conditions. We take that into consideration along with the ABGs. So ABG is 3 key components: your pH level, your PA carbon dioxide level, and your bicarb level. CO2 is exhaled and produced with carbohydrate metabolism. So, just by exercising, it causes an increase in respiratory rate and depth. And to compensate for the increase in metabolism of carbohydrates, that's why we have that change in breathing. That's a normal type of acid-base balance that come into play. So this is not just in disease processes. This is just in normal body metabolism and keeping things in balance. But those are the three big ones you want to have at the forefront of your mind. So we need to talk about dehydration. There's two different fluid conditions, dehydration versus overhydration. Let's talk dehydration first. So that happens when water lost is not properly replaced. We have to maintain a daily oral intake approximately equal to daily fluid loss. Who's the most vulnerable for having a problem with this? Infants, older adults, confused clients, bedridden clients, those who are comatose, and people who are receiving highly concentrated tube feedings. For example, a hypertonic tube feeding. What causes dehydration? Prolonged fever, watery diarrhea, renal failure, hyperglycemia. So dehydration is when fluid intake or fluid retention is less than what is needed to meet the body's fluid needs, which results in a fluid volume deficit. When someone is dehydrated, the circulating blood volume is decreased, and that can lead to inadequate tissue perfusion. If a client is dehydrated, they may become confused. If this happens, they may respond to oxygen, so you could throw some oxygen on them to help balance things out while you figure out what's going on with them. Because if they're dehydrated, there is not sufficient blood flow to the brain. Another key indicator of dehydration is a high pulse rate. Often people who are dehydrated will have a low blood pressure and a high heart rate, and this is the body trying to compensate for the low blood volume. These people can also experience orthostatic hypotension. If they feel lightheaded or dizzy when they stand up, a quick intervention is to have them drink a full glass of water. If they do this, we should see their pulse and blood pressure normalize. Okay. A little bit more on dehydration. These are the key signs and symptoms. These are the tests. This is what we're going to do. We're going to treat them with either oral salt-free fluids like a hypotonic solution like D5W, but we want to be cautious because too fast of an infusion can cause fluids to move from the veins into the cells, causing edema, including cerebral edema. What are the signs and symptoms of cerebral edema? Headache, confusion, irritability, lethargy, nausea, vomiting, low heart rate, and seizures. What are our nursing considerations? Anybody who's dehydrated and getting replacement fluids, we want to be cautious and monitor vital signs, intake and output. We want to monitor their presenting symptoms. We want to maintain IV access, sodium levels, check urine osmolality. We may need to assess the need for a Foley catheter to closely monitor urine output. And we want to watch for diaphoresis, loss of fluids through perspiration. And of course, daily weights. Now, what if they have the opposite problem? They've got too much fluid. So that happens with excessive sodium or fluid intake. So that could be through IV normal saline or LR. They could have gotten blood replacement, specifically multiple units of blood, or they could have a high dietary intake of sodium. You could have something where they have fluid or sodium retention. For example, disease processes like heart failure, liver cirrhosis, nephrotic syndromes. They could be on glucocorticoid steroids. They could have a condition like hyperaldosteronism or even low dietary protein intake. So, causes. All those things listed on the slide are it in a nutshell. Um, so, who's most vulnerable for fluid shifts? That's the fourth thing on this slide. People that have post burns, people that received hypertonic fluids, or people that have received plasma proteins like albumin. Otherwise, what we're talking about is too much fluid or sodium intake, retention of too much, usually due to a disease process, or they've got a renal failure problem where they can't get the urine out, or lastly, the fluid shift issue. So the body can compensate through the aldosterone, ADH, and atrial peptide systems, but symptoms will develop if those mechanisms fail. So who's most vulnerable for this problem? The elderly or those who have impaired renal or cardiovascular systems. And know that excess fluid can cause heart failure or pulmonary edema. So, what are the signs and symptoms? I would know the items listed on this slide and know that edema. Edema is usually first shown up in dependent areas. Then if things progress, it becomes generalized. Then it becomes anaskara, which is just the medical term for severe generalized edema. Their skin's going to look puffy and feel cool to the touch. And remember that edema happens when hydrostatic pressure pushes fluids out of blood vessels into the tissues. Pulmonary edema, that is when the left side of the heart becomes so overloaded and there's a decrease in effective pumping that it leads to backup to the lungs. So the signs and symptoms are crackles, shortness of breath, increased respiratory rate, or a very bad sign, pink frothy sputum. What tests are we going to do? We're going to do hematocrit hemoglobin, which usually the hematocrit is going to be low because of dilution. We're going to look at their potassium levels, their BUNs, the osmolality, their oxygen levels, and the sodium levels. We could do a chest x-ray, which may show pulmonary congestion. And if they do have pulmonary congestion, that is a potential emergency. How are we going to treat it? What are our nursing considerations? An important thing is to administer the prescribed diuretics as ordered to help alleviate symptoms. We're also going to monitor vital signs. We're going to monitor signs and symptoms, especially respiratory system and edema assessment. We're going to keep the head of the bed elevated as long as their blood pressure tolerates it. We're probably going to put a Foley in these patients because if we're given diuretics, they're going to have a lot amount of urine to come out. We're going to maintain IV access, and we're going to watch closely for signs and symptoms of dehydration due to overcorrection of the problem. We're also going to monitor intake and output. We're going to monitor ABGs, acid-base balance, and potassium levels, electrolyte balance. Which leads us to acid-base imbalances. So acid-base balance depends upon your hydrogen ion balance or concentration. Remember your pH scale. Greater than 7 is alkaline or basic. Less than 7 is acidic. Remember that hydrogens are acidic. And just a word on compensation. Respiratory system is more sensitive to acid-base changes. It can begin compensating in seconds to minutes and last for hours. But the kidneys are more powerful. They respond to rapid changes in extracellular fluid, but fully triggered for imbalances can take several hours. So it's not as sensitive, but it's a more powerful reaction because it can last for several days versus the lungs, which can't maintain for days. We just can't physically do it. And that's when we see respiratory failure kick in. Okay, so let's talk about the acid-base imbalances. There's 4 main ones. So we've got, first of all, respiratory acidosis. The pH is going to be less than 7.35 because with acute respiratory acidosis, the kidneys don't have time to compensate. If it's chronic respiratory acidosis, the pH is going to be normal because the kidneys have had time to compensate. The test that we're going to do ABG. The PaCO2 is going to be greater than 45. The PaO2 is going to be low. And the bicarb levels are going to vary depending on how long the acidosis has been going on. We're going to look at the chest x-ray to look for conditions like COPD, pneumonia, pneumothoraxes, or pulmonary edema. And potassium levels. Your potassium level is going to be high because potassium is leaving the cells. And we're also going to do a drug screening for these patients. So this slide just gives you the acute, partially compensated. I would focus on the acute condition for this term. As you progress to next term, Lisa will give you additional information about the compensation process. Respiratory acidosis continued. So acidosis, your K is going to be high. That's our little reminder in the top left corner. What are the signs and symptoms of respiratory acidosis? Rapid shallow respiration, dyspneic, diaphoresis. They could complain of headache because of CO2 causing dilation of the cerebral blood vessels. You could see central nervous system depression, such as altered level of consciousness. You could hear decreased lung sounds or even absent. They can have a tremor, hypotension, arrhythmia, progressing to shock and cardiac arrest. How do we treat it? We are going to give bronchodilators to open the airways, give supplemental oxygen as needed, treat the hyperkalemia, antibiotics if it's an infection, anti-inflammatories or chest physio or mucolytics for secretion problems, or even an artificial airway. The focus for respiratory acidosis is improving ventilation and oxygenation while maintaining a patent airway. And the nursing considerations are listed on this slide. Versus respiratory alkalosis. And the most common cause for respiratory alkalosis is anxiety or panic attacks. Acute respiratory alkalosis is a sudden increase in ventilation. Chronic respiratory failure is difficult to identify because the renal system compensates. Again, focus on the acute condition values for this term. Remember that alkalosis means the K is low. So, the nursing considerations are listed on this slide. What are the signs and symptoms of respiratory alkalosis? Increased respiratory rate and depth, dyspnea, increased heart rate, Anxiety, restlessness, lightheadedness. We can see EKG changes. As it progresses, we could see a decreased level of consciousness, seizures, comas, and decreased cardiac output related to vasoconstriction in response to the hypoxia. In extreme cases, we're going to see confusion and syncope due to the lack of CO2 in the blood and its effect on the brain. We may see alternating apnea and hyperventilation with respiratory alkalosis. Tests, we're going to see an ABG. The pH is going to be greater than 7.45. The PaCO2 is going to be less than 35. With acute, the bicarb is normal. With chronic, the bicarb is going to be less than 22. Treatment, we're going to treat the underlying disorder. Is it fever? Is it sepsis? Is it hypoxia? Is it pain? Is it anxiety? Treatment, breathe into a paper bag, which will raise the carbon dioxide levels. If that's not successful, we could do mechanical ventilation. All right, so then we switch over to metabolic acid-base imbalances. So if it's from the ass, it's acidosis. If it's from the mouth, it's alkalosis. If it's alkalosis, the K is low. If it's acidosis, the K is high. So vomiting. Vomiting, you're losing too much acid, which is hydrochloric acid, which causes us to have too much base. With diarrhea, you're losing too much base, leaving too much acid behind. So let's talk metabolic acidosis. Caused by too much acid production. It could be because of overproduction of ketones. You could also have excess GI losses or toxicity. So causes. Overproduction of ketones due to diabetes mellitus, alcohol abuse, severe malnutrition or starvation, poor carbohydrate intake, hyperthyroidism, or if you have a severe infection with a fever. Versus causes excess GI losses due to diarrhea or intestinal malabsorption. This can be made worse by lactic acidosis, which can occur related to shock, heart failure, pulmonary disease, liver problems, seizures, or even strenuous exercise. So there's really two methods, either too much acid or too little base. Remember to focus on the acute condition for this term. Metabolic acidosis continued. Prevention is number one. Then picking up on it early. So what are the signs and symptoms? Initially, your respiratory rate, depth, and rhythm changes to neurological cardiac conditions. Then as acid builds up in the lungs, they're going to compensate by blowing off CO2. So usually hyperventilation is the first clue, or Kussmaul respirations. These patients can also have muscle weakness, which leads to flaccid paralysis, a decrease in cardiac output, low blood pressure, arrhythmias due to hyperkalemia. Their skin may be warm and dry and then cool and clammy. They may complain of a dull headache. They may have decreased level of consciousness, and it progresses to confusion, to stupor, to coma if we don't correct it. Tests. ABG is key. You're going to have a pH less than 7.35, PaCO2 of less than 3.5 or normal. EKG changes related to the hyperkalemia. Remember that the hyperkalemia is due to excess hydrogen ions moving into the cells, pushing the potassium out of the cells. In DKA, you're going to have increased blood sugars, increased ketones, increased lactic acid, increased ion gap. How do we treat this? Correct the acidosis by treating the underlying cause. Number one, respiratory compensation, including mechanical ventilation. Sodium bicarb to neutralize the blood, but only act on this order if the bicarb is low on the ABG. We're also going to use fluids, potentially dialysis for toxic or renal patients. We could use antibiotics if infections is the underlying problem. For DKA, we're going to use rapid acting insulin, and it works two reasons. The first is it treats the hyperglycemia. The second is it drives potassium back into the cells. But we do have to watch carefully because the potassium levels can go too low if we overcompensate. Then we've got metabolic alkalosis, caused by a loss of hydrogen ions or a gain in bicarb. Most common cause is excess GI loss by vomiting or prolonged NG suctioning, but there are many other causes. They can include things like Cushing's, kidney disease, multiple blood transfusions, glucocorticoid steroids, or even antacids. If low potassium occurs, which is frequently a common issue, the kidneys conserve potassium and then they increase the excretion of hydrogen ions, which causes alkalosis from the loss of acid. Again, focus on knowing your acute condition for this class. Metabolic alkalosis continued. Signs and symptoms. So initially, there's slow, shallow respirations as the lungs try to compensate. But then hypoxia develops, which stimulates ventilation. Neuromuscular excitability, like muscle twitching, but you could also see tetany, hyperactive reflexes, numbness, tingling of the fingers, toes, and mouth. You can see neurological changes like apathy, confusion, seizure, stupor, coma. Due to hypokalemia, you can see anorexia, nausea, vomiting, arrhythmias, or death. Tests, you're going to do an ABG. It's going to show a pH greater than 7.45, a bicarb greater than 2.6, or normal if it's due to excessive acids. Your PaCO2 is going to be greater than 45 if the respiratory system is compensating, or it may be low. You could see low potassium, calcium chloride, and you can see EKG changes. Treatment. We're going to correct the acid-base imbalance by giving the body time to get rid of excess bicarb and increase the hydrogen level. Very rarely, ammonium chloride is given. We will discontinue any thiazide diuretics or NG suctioning. We'll give antiemetics. We will use Diamox to inhibit calcium and increase the renal excretion of bicarb. So that brings us to the end of the four main abnormal acid-base conditions. In addition to what I've said, I would focus in on the nursing considerations that were listed on each slide and that you have in your handouts. So the last few slides of this presentation are a review of the electrolytes, the big four. So first one is potassium review. Low potassium. Some things to know are what are the signs and symptoms, what are the causes. Know that Lasix is a diuretic that is notorious for causing low potassium levels, so we need to monitor lab values very closely. And the treatment for low potassium depends on the severity. They may need to increase their oral potassium-rich food intake. They may need oral or IV potassium replacement. Some rules about oral potassium: must be diluted with water or juice and followed by a large glass of water. IV potassium must be diluted and can never be given IV push. If we give any type of potassium too fast, it can cause fatal hyperkalemia. IV potassium has a maximum infusion rate of 10 milliequivalents per hour through a peripheral IV. Switching over to hyperkalemia. Know your signs and symptoms, know your causes. Know that clients who take an aldosterone inhibiting medication like spiralidactone are at a higher risk. So again, monitor those lab values. How are we going to treat high potassium? Well, we're going to monitor the pulse closely. We're going to try to eliminate the cause of the excess potassium. We could do a food intake restriction for mild hyperkalemia. For moderate to severe, we could use IV sodium bicarb. We can use K-Exolate. We can use calcium gluconate and a combination of insulin and glucose. For both high or low potassium, place these patients on a cardiac monitor and monitor their pulses apically. Sodium review. Low sodium, know the signs and symptoms and causes. There's either going to be a sodium loss, deficient intake, or water gain. Treatment is going to be oral sodium replacement, or if it's severe, a hypertonic IV fluid like D5W with normal saline. For high sodium, it's usually due to a sodium gain, sodium retention, or water loss. Treatment is typically a sodium restriction, IV fluid, and diuretics. Sodium restrictions, it's important to give your patient education to avoid canned foods like soup, fast food, and foods like ham. We want to encourage them to eat chicken and fresh or frozen vegetables instead of canned. Calcium review. Know the signs and symptoms and causes for both. With low calcium, remember Charcot's and Trocheau's signs. Charcot's sign is that twitching of the facial muscles in response to tapping over the area of the facial nerve. Trocheau's sign is the carpal pedal spasm caused by inflating the blood pressure cuff for a few minutes. Treatment of low calcium, oral or IV calcium. Remember that we need to take oral calciums with vitamin D 30 minutes before meals, and cardiac monitoring is a very good idea. With high calcium, our treatment is again cardiac monitoring. Then we can expect to give calcitonin or IV fluid rapidly infused, followed by a loop diuretic to promote excretion. This one slide is just a reminder about those BMP, what comes in a BMP, what lab values to look at. Reminder that calcium and phosphorus have an inverse relationship, and so does excuse me, sorry, I lost my train of thought there. So does sodium and chloride as well. This is a reminder for you to review the IV infusion PowerPoint that was given out in week 2 and some key points for central lines that include picks, midlines, Groschongs. When seeing a pick, be sure to measure the length of the catheter to ensure it did not break off inside the body and document the length. Be sure to educate patients not to lift heavy objects with the arm that has the IV line placed in it. And be sure that we're flushing before and after administering medications through a central line. And then lastly, just some things to focus on for this unit is our normal values for these electrolytes, hyper and hypokalemia, hyper and hypocalcemia, acidosis versus alkalosis, dehydration versus overhydration. Okay, that brings me to the end of this presentation. Thank you so much for listening.